I would like to call the meeting to order of the Committee to Study Long-Term Managed Care. Our first order of business is going to be to approve the minutes of the previous meeting. Do we have a motion to approve those minutes?
I move.
Seconded. I'm sorry.
All right.
Seconded.
All in favor say aye.
Aye.
All opposed? Abstentions? All right, minutes are approved. So, with apologies to all of you who are here to, have been here all along, the draft report, there is a draft report. I sent it out to the other committee members at 1:30 in the morning last night. And so I think what we want to do today is just walk through that. As I had discussed previously, the intention here is to issue a preliminary report in time for the deadline on Wednesday, which essentially frames the issues, describes the key considerations that would need to go into a decision about recommended legislation, and then to lay out a few options for legislation, although we're not at this point making any recommendation among those options. And I also think that there are some unanswered questions with respect to the federal legislation, the Big Beautiful Bill, or OB3, as I've been calling it, which I think need clarification. And given the scope and depth of that legislation, I think it may be a little while before we get clarification on some of those questions. So with that, I guess what I'd like to do is just sort of begin by walking through the report, which currently says final report, and I'm not sure if final report will be edited or not. As I've said, this is in my view, a preliminary report. So essentially the first page following the cover page is laying out the mission of the committee that was created in HB2. It lays out the language from HB2 regarding the committee's mission. The next page has the same things. The following page just includes meeting summaries. And then we get to what I consider to be kind of the meat of the report, key issues and considerations. So, in order to assess various alternatives, we wanted to identify key issues about, should we move forward with managed care? Should we refrain from moving forward or take some intermediate steps towards expanding managed care and the role of MCOs in the state for long-term services and supports? So the first consideration listed here is county nursing homes, Medicaid, ProShare, and MQIP. A lot of this is kind of a repeat of what we discussed last time, but essentially Medicaid patients are getting a daily rate that ranges from about $250 to close to $350 a day, depending on acuity, and that does not cover costs. The remainder of costs are covered with these intergovernmental transfers and or provider taxes. So in the case of intergovernmental transfers, we're getting ProShare sort of matched and rebated to county nursing homes at $100 to $150 a day when you do average it all out. And then MQIP, which is also available to private nursing homes, amounting to about $74 a day. So I guess the conclusion I had come to is that those are obviously essential to nursing homes. Under a managed care model, those payments would be eliminated pursuant to federal law because you can't do that and You can't have those state directed payments and managed care coexist. Some states, including Texas, have operated under waivers that allow for managed care organizations to provide quality incentive payments, and that could potentially be an alternative. However, that exists under a federal waiver, which is subject to change at the discretion of the federal government and could potentially go away. And if it does, that would lead to another $60 to $70 million of costs falling on the counties, which would directly impact property taxes. So that's kind of that's a summary of what's in this section. Is there any questions or comments about that?
Not in this section, no.
Okay.
Nope.
You good? All right. The next section refers to managed care organizations and just highlighting their role, their existing role in the state for Medicaid, and then highlighting the potential role that they would play in a long-term managed care model. I did pull some information about the experience of other states in terms of cost, because one of the reasons cited for moving to managed care is cost savings, and there are a couple of examples that stand out. Two that show fairly significant cost savings. One that clearly does not. So I've highlighted some examples, and I've cited sources there for Florida's program achieving savings of $284 million in the 2014-15 biennium, $432 million in the 15-16 biennium, and $200 million annually after that. Tennessee increasing community-based residents from 17% to 44% by 2015, which has contributed to some cost savings. And then California, which has seen costs go up despite their rollout of managed care, and so again, that's been in place since the early to mid 1990s in California. So, any questions or comments about that?
I do have
section?
one, yeah.
Yes.
I am very concerned about one of the states that's not mentioned in your report. The Indiana experience, it worries me. Indiana, in some ways, is very similar to New Hampshire. Demographically, the northwestern corner is a bedroom community for Chicago, just like our southeastern corner is for Boston. And the rest of the state is more rural and older, although they don't come close to our second oldest in the country rank. But when they instituted managed care for long-term services and support, they actually lost a significant amount. I think it was in the $300 million range it cost them. And a couple of folks testified to that effect. The population of Indiana is about 6 times New Hampshire's. They're 600 million plus. 6 million plus, and we're 1 million plus. But demographically, we're older. If you were to divide what they lost by 1/6, we'd be looking at a $50 million deficit that the state would be probably passing on down to property tax as a way of making up that loss. So I think Indiana should be included in the list of the examples.
So I think that's a very good point, and I apologize for omitting that. I actually think that, I guess what I would propose is that we add a reference to Indiana and the numbers there. It probably would benefit us to look across other states as well. Texas has been cited multiple times, and I also know that some of the structure of the plan determines, how profitable it is, or how expensive it is, rather. The other, and then there's some key difference as well in terms of the number of enrollees in the state, the size of the market for MCOs as well, and that impacts cost efficiencies and other factors. So I think for now, what I would propose is adding another bullet point with Indiana and pull some of the data from the article that was shared with us. Other comments or questions on this one?
None at this time.
Okay. The next section refers to dual eligibility, and it's just sort of an overview of what dual eligibility means and the number of dual eligibles in New Hampshire. And again, sort of highlighting that, integration of Medicare and Medicaid to both reduce the administrative expenses, and also to improve health outcomes is potentially a value add in this process. Then we move on to DSNP and PACE, and this is largely based on the information that was shared with us by DHHS, kind of laying out what is DSNP and PACE, and then we discuss that a little bit later, and then go into talking about CFI waivers. So a lot of this report is kind of for somebody like me who is not necessarily familiar with these issues, kind of lay out what, sort of summarize and elaborate on the information that we reviewed last time around. We also, I think, have further information both from a state comparison point of view. The information that we got from Melissa Hardy this morning, I think, could be beneficial. Probably not in this initial report, but as we look to the future and adding some additional meat to the report.
Yeah.
So I want to talk about the One Big Beautiful Bill next, but is there any further comment before we get there?
No, not right now.
Okay. So I think one of my biggest concerns about this is that I think there are still many, many unanswered questions about the One Big Beautiful Bill, and just being mindful of the timing. House Bill 2 passed at the end of June, and the One Big Beautiful Bill was still in the process of being finalized and enacted around the same time. So I think it was too early, perhaps, to understand very much at all about it then. I still think there are a great many unanswered questions. So I think we need to answer some of those questions and understand the implications before we really can choose from among the recommendations. But some considerations that I've seen, and there may be others that we want to add to this list, but DSNP incentives, it's unclear to me. So there's some new administrative requirements around dual eligibles. It's unclear to me at this point whether or not there are incentives in place. And Mr. Lippman, I don't know if you are able to answer these questions, whether the OB3 Act is incentivizing states to move to DSNP and or what that looks like, or if either of you have answers to that.
Good morning. For the record, Henry Lippman, the State Medicaid Director. In terms of the DSNP question, I want to go back and check that. I could send an email to you to confirm what my understanding is. I think generally still there's, if you look at the rural healthcare transformation program, there is one of the goals is trying to build the relationships in for dually eligible is one of the areas that is a goal of the administration in that space. But I'd have to go back to the bill to confirm what that is.
Okay. All right. I do have another question unrelated to that. So I'm just trying to understand sort of from a market perspective. We know, New Hampshire has seen, I'll say, lack of consumer choice in the health insurance market, and I think that's been a detrimental thing for New Hampshire residents. If we look to the Medicaid community, right now we have 3 MCOs, and that provides, I think, a very good range of choice. We talked a little bit last time about HCBS, and if there were a carve out, and I think the point that was brought up is, well, there may not be enough of a market there, and that got me to thinking about sort of the bigger picture with declining enrollment and tightening eligibility requirements. Are we in a position where there is a risk of New Hampshire being a less attractive market for MCOs and therefore less consumer choice?
So I think the threshold for viability that is 50 to 60,000 members is what we saw when we did RFP for bidding in the last couple of reprocurements. So we're getting close to that minimum. We have 2 MCOs that are slightly above 60,000 and one just hovering under 50,000. That's been above and below it over time. So there is a concern, about maintaining 3 in the long term.
Okay. Other questions related to any of those?
None of this.
No. Okay. So as far as DSNP is concerned and the OB3 Act, that's just an example of where I'm sort of getting incomplete information from other sources, and it's I would think that if it's not clear to you and it's not clear to a lot of the other experts in the field, it's there's time yet for it to be clarified, and so I think that's part of my concern is there's so many unanswered questions that even the experts aren't quite sure how it's all going to play out. So the other bullet point under the Big Beautiful Bill was limits on provider taxes and phase out of SDPs. And so I did have a question, and this is if we went to a managed care model, then MQIP and ProShare would be at risk, or would be prohibited under that if we were doing a managed care model for patients in nursing facilities. So there's 2 elements to that. There's provider taxes and there's intergovernmental transfers. And so the IGTs, I've also heard mixed messages from various sources that I've researched on whether or not IGTs are going away outright, or whether they kind of fall into the same category as provider taxes, which is if you have them already, you can keep them, but you can't increase them and you can't initiate new ones. Do you know whether it's whether they're going away or whether it's in that latter category?
So I can comment in 2 respects here. In terms of the ProShare is drawn not on a IGT but on a certified public expenditure basis.
Okay.
So right now all our county nursing facilities are using the certified public expenditure, which is basically presenting the cost of using a cost report, and that the federal government will match half of the unreimbursed costs, if you will.
Okay.
Up to the Medicare limit.
That's helpful to understand. So the question of IGTs actually is irrelevant.
And the county cap is actually the intergovernmental transfer. And I think intergovernmental transfers aren't going away. I think New Hampshire's is pretty vanilla. Some states have, some facilities that are questionable that they're really governmental facilities. I think it's clear that, counties here in New Hampshire are clearly part of state government structure. I think, I don't see anything, I haven't seen anything that would suggest that that's at risk in terms of the policy issues that have been raised in other venues.
Okay. The other consideration that's been brought up with respect to ProShare and MQuip is those would be prohibited under a managed care model for nursing facilities. The alternative could be for MCOs to make incentive payments to those facilities. That's authorized under a waiver program. If that waiver were not granted, not renewed, etc., then that leaves nursing homes, with another county nursing homes only with another 60 to 70 million, and private nursing homes with the MQuip to make up. So, if there were legislation that said we want to go to a managed care model, but if we don't get the waiver, we want to roll back, are we kind of stuck at that point that we can't roll back to that because OB3 prohibits, what they call new provider taxes?
Yeah. I guess maybe it could be drafted that absent a waiver, we don't proceed versus the other way around, which is if we proceed and then we go back. I guess you could handle it both ways. One is don't get into it unless you've got the financing covered, and then an alternative to relook at it if in fact is removed. I just want to say that as much as CMS does sort of move the ball on people, move the cheese now and then, I think when it would come to something like this, it probably, as long as what the state is doing is not playing some games, if you will, or doing something that's not directly in the the black area. I don't think there's a huge risk there. I think that the point I was making is that, for example, the state of Maryland had a waiver unrelated to long-term care that had been in place for 20 years, and that they're having to evolve from where they are. It's not like they can't do anything, but what they had is a clear, long-established waiver isn't going to be renewed. I think there's some, I think risk there, but I don't want to have you overstate in the report above what it really might be.
Understood, and I've sort of assumed that it is a low risk. However, for the county nursing homes, it's not a low risk. It's,
Yes.
it may be a low risk, but it's very, very high impact risk.
Yes.
And so therefore high impact on
Yes.
taxpayers who are paying property taxes to the county. Okay, so it seems like that. So there's still a kind of unanswered question, which is, if we, I understand the distinction between we won't proceed unless we have the waiver versus we'll roll back if we don't get the waiver. Even the concept of rolling back means more disruption, more redesign, more expense. But I guess there's again, it's probably calls for some kind of a statement of opinion from somebody in Washington to say, yes, you could go back to your current model, or no, you can't, because OB3 explicitly prohibits new provider taxes or increased provider taxes. So if we roll it back to zero, we can't go back to where it is today.
The tax could still be collected and used towards the funding process. So I think there is a risk if we eliminate the tax that we might not be able to get that back based on because there's a prohibition against new taxes, and so so I think that the tax would have to be part of the current tax would have to be part of the financing solution that obviously would have to also make the counties and the privates comfortable that there's going to be, a chance to get that money back in a positive way for them.
Okay. So presumably we could collect the tax, we could rebate the tax, we just couldn't get it matched under a managed care program.
Rebate would be probably maybe not what we could do, but I think in terms of going into it, we'd want to have assurances that what we were doing didn't risk that probability that we would lose that as a financing mechanism, because that's the underpinning of a lot
All right.
of the program.
Okay. Other questions?
No, not.
Okay. So I don't have other questions for you right now, but I might. So I don't know if you want to stick around or not. So the next section is population served by long-term services support, and in this, I have said, and then I'm going to ask my fellow committee members here. The committee must consider whether any potential move toward long-term managed care service and support should apply to all covered patients or only to a subset, such as elderly, developmentally disabled, or acquired brain disorders. And I've used the term elderly. I think aging population is the what is the correct terminology? Okay, I think we're all aging, so all right. So I will change that to aging population. So I think we have heard that there is not an appetite for DD and ADD going to long-term managed care. We're not sure if there's an appetite for aging population going to long-term managed care, but I think we want to, as a committee, probably recommend staying away from DD and ADD at this point. Do you agree?
Agreed.
Okay. Great. So I think we can go ahead and make that recommendation. So with that, so that kind of lays out for somebody who's reading this for the first time and like me kind of needs an overview of the issues. I think it lays out as much as we know. I think there are still some unanswered questions, primarily around the OB3 legislation. The rest of the report outlines 4 potential approaches to legislation, and I want to be very clear that at this point, I haven't figured out which of these I would favor or not, and I don't think the committee is prepared to do that unless or until we have further information. But I do want to sort of spell out what those 4 are that have been identified. Number 1 is maintain the status quo, do nothing. Number 2 is to adopt DSNP, where MCOs are managing the dual eligibles in New Hampshire. And that is the program that DHHS has already explored and is looking at potentially submitting an application to do that as early as 2027. Yes. Okay. So the earliest I'm sorry. I understood the earliest you could roll it out was 2028, but you're saying the earliest you could submit the application is 2028? Okay. All right. I would, when we're done here, I'd like to actually have you go through that timeline again, because I'd like to understand what the constraints are there. The third option is to adopt the HCBS carve-out model, where we're preserving a fee-for-service model for nursing facilities, but addressing the home and community-based services as a distinct category. The concern here, I think, is that it is not probably a large enough population to be economically viable as a program. But that's something that we would need to explore further. And then option 4 is to is essentially full speed ahead on managed care for the aging population. So those would be the 4 models, and I'm sure there are variants on those, and there may be others, but I did leave DD and ABD out of this, assuming that we would be on the same page there. So that's it essentially. That is the what I'm calling a preliminary report. Any additional discussion, questions, comments, or other information that you think we need to collect? Because part of what I want to come out of this doesn't necessarily have to be in the report, but I want to be generating a list of what questions do we need to get answered,
right. What
are the things do we need to look at. You identified needing to look at other states in more detail. I think we've got questions about the OB3 Act. But what else? What else have you got?
Just a couple more things. The status quo option number 1.
Mm-hmm.
I think it would be good to include what's been accomplished with that to date, and that would address that increase in utilization of HCBS since the original Association of Counties report in 2018-2019. There's been a substantial decrease in nursing home utilization and an increase in home and community-based support. So I think that is a consequence also that would be part of maintaining the status quo. Mm-hmm. And then option 4, I think you pretty much covered that. That's it for me.
Okay.
Yeah, that would make sense. I can see that. Thank you.
Okay. So I'm at a little bit of a loss as to how we proceed with having an approved report, because we have some edits that need to be made here. Mm-hmm. And so, I guess what I'd like to do is perhaps something similar to what we do with meeting minutes, which is go through the changes that we would like to make in this preliminary report. And I certainly would share that with you before putting it out and sort of get an okay from you. But I would like to perhaps go through those, then deliver the edited report to you, have you say, yes, this is what I voted yes on. But I would like to have a vote on sort of, are we comfortable with this as a report for now? So the first, if I go sort of kind of starting from the beginning, the first thing I have is adding a bullet point for Indiana under the states and citing information from the articles the article that was shared with us from multiple sources, so that we can cite that one as well. I think not for the preliminary report, but longer term, I think it would be good for us to include information from other states, because I'm hearing a lot about Texas, for example. Mm-hmm. So I think we could do that as well. The next change on my I have to now go back to DSNP and PACE. Okay, I don't mention intergovernmental transfer. Oh, sorry, not DSNP and PACE. ProShare and MQuip. I don't think I specifically say intergovernmental transfers. If I did, I would need to correct it. I don't in that case. And I think we're good with the way, I wish I had page numbers on here, but under the sections called changes to federal law, OB3, the second bullet point, limits on provider taxes, references IGTs. but that still is accurate. So there's nothing inaccurate there. I just wanted to, being mindful of what Mr. Libman shared with us. Not for this report, but for the future, I think we need to better understand sort of how the county cap as an IGT might play into this with respect to changes in federal law. I do understand IGTs are not going away. I just want to, I have a lot of questions about sort of some of the very technical details of how SCPs and IGT and provider taxes would all be affected in the event that we went to managed care with incentive payments and then had to reverse course. I don't think anybody wants to do that, and we're going to recommend that. But I think we also need to consider what's the fallback if we don't get a federal waiver, or if we get a federal waiver and at some point it's withdrawn or not renewed. And again, understanding the likelihood of that is extremely low, the impact of that is extremely high. So I think that's information we need to gather for the future. I'm also going to be changing the terminology where I've used the word elderly. I'm going to change that to aging population. I have in population served by LTSS in the first paragraph, I'm missing, it says whether any potential toward LTMCSS, that should say any potential shift or move. So I'm missing a word.
Where is that?
That's in population served by LTSS, whether any potential shift toward LTMCSS. And then under the legislation options, I think we can certainly add to option 1 the fact that there has been substantial improvement in the shift towards HBS. And I don't necessarily want to try to dive deep into details on stats, but I think it's worth pointing that out here. And then under option 2, changing DSNP could be submitted as early as 2027 to 2028. So those are the changes. If you want me to go through them, and the word final, where it says final report, we may need to change that to interim report or preliminary report.
Whatever the appropriate term.
Yeah, we'll figure out what the appropriate terminology is. So adding Indiana, adding the word shift, changing elderly to aging population, and adding a reference to progress that's been made since 2018-19. And then under option 2, changing 27 to 28. Those are the proposed changes. Yes, Mr. Whitman.
So I think that going back over the report in terms of the earliest we could do it is for implementation would be 1/1/28. The issue is looking at all, like implementing work requirements and implementing all the other things that we have to implement. I think that's where we were concerned that maybe it wouldn't start until we had a new contract period, which would typically be start of a state fiscal year. But I think technically we could begin if 1/1/28, but that would take some decision making early, because you have to, in 27 you have to give your notices and so forth. So I just wanted to clarify that.
So it's feasible in 27, but with
Everything.
other changes coming down the pike, it will be challenging. So you would need additional resources,
Yeah.
or
I think we'd probably we'd have to notify them in November, which is before you would do legislation this November. So I think realistically, with everything on the plate and everything, it would be 1/1/28 would be the earliest that we could do it, and then even in terms of lining it up with contract changes with the plan. But I think theoretically it could be 1/1/28, but maybe July 1 of 28, maybe more realistic, winding it up with a new state fiscal year, new state budget.
Okay, so July 1st, 28 being implementation, or
Yeah, I mean, I think that would theoretically it could be 1/1/28 we could implement, and I would have to go back to see in terms of making sure with Medicare choices, right, whether there's a certain open enrollment period for people to choose to be involved in what their plans are. So 1/1/28 may be practically where it could be effective, but people would have to
Nobody
know in
can sign
advance
up
to
for
make
it.
their
Yeah.
choices.
all right. Okay. All right. Thank you. All right. So I guess I want to, before we sort of vote on that final product, I want to, and I apologize that this has not been available for review prior to this meeting, but I just wanted to invite any stakeholders who are in the room who would like to add their 2 cents, comment on what they've heard, to come forward if you have something to say. Nope. Okay. So with that, I will ask if we have a motion to approve the preliminary report as drafted with the changes that we have agreed on.
I so move.
Second.
All right. All in favor, say aye.
Aye.
All opposed, nay. All right. Very good. Then I will, my next step will be to make the changes that we have discussed today, provide both of you with a copy of the report so that you can confirm that those changes are what you expected and what we agreed on, and then we will get the report issued on time. As far as next meetings are concerned, I am going to be attending a briefing on some of the federal legislation and impact on states in a couple of weeks, 7th and 8th, I think. If I'm thinking that if we can do something either towards the end of October or sometime in early November, that would give us a little bit of runway. At the same time, I still have this sense that a lot of people, including the experts, are still going to be getting their hands around sort of what are the implications of all this. But knowing that most study committees are aiming for a November 1st due date, I would like to, I'd like to have something done and issued certainly by the end of November. Even if we acknowledge in that report that we don't have complete information at that point, we can call out the points that are not clear and issue a report. So, what would the two of you propose as a general timeline? Does it work to meet in sort of end of October, beginning of November?
Yeah, as long as it's not. Excuse my cough. As long as it's not after, as long as it's before November 2nd.
Okay.
I think the end of October. In order for you to have some time maybe to give us some input on what you learned at your conferences.
Okay. So would Monday the 27th at 10 a.m. work?
October?
Yes.
Oh, okay.
That's good for me.
Yep.
All right. So it'll be Monday, October 27th, 10 a.m. For folks from DHHS. Does that work? Monday, October 27th at 10 a.m. That works? Okay. All right. And with that, any additional discussion, any additional business for the committee?
Not at this time, no.
Yes.
All right. Then I think we can adjourn. Thank you everybody for being here, and
Thanks
thank
for
you
all
to
your
my
hard
committee
work,
members. All right, thanks.
burning the midnight oil.
They pay me the big bucks for.
PDF copy of the bill with me, and I've done searches on those special needs
Oh.
plans. I haven't found anything yet, but I'm going to Washington actually this afternoon. I'll see if I can
Okay.
talk to anybody that might
All right.
know something.
Yeah. Anything you can, well, not anything you can do to help educate me. Anything that can efficiently help to educate me is helpful. Yeah, so I'm going to a thing October 7th and 8th. I'm going to another thing in November that NCSL is doing in